Yeah, thank you very much, Nate. My name is Gingong Anthony. I am the director at the National Health Insurance Authority, responsible for provider payment and coordinating the rollout of capitation nationwide. I have been with the National Health Insurance after almost 20 years service with Ministry of Health and Ghana Health Service as a district director. So I came with the provider experience 6 years ago and have since been working. At the National Health Insurance Authority, I came as a deputy director in charge of operations. I became director of operations and I handled quality assurance as director of quality assurance before I moved to handle the current position, which is provider payment systems. At the NHIA, which is the agency responsible for paying providers and then also registering subscribers, we realized that we had very high utilization rates in the Ashanti region, and then we decided to pilot to see whether if we capitated primary care alone, it could bring down substantially our cost or our bills, which we did in 2012. We rolled it out in 2012, but we had started the preparations in 2010 with a lot of community sensitization, stakeholder engagement. The pilot taught us a lot of lessons, and that is what is helping us to roll out successfully in the other 3 regions. For example, the pilot taught us that we did not go in with the appropriate message, and that the communication strategy we used was fraud and was not appreciated. It was more academic than practical. The pilot also taught us that there was no stakeholder buy-in before we roll out. And then the pilot also taught us that our timing for the rollout was poor because we decided to roll out in an election year, forgetting that health is nothing but politics. And these lessons behind us, we have been able to design a system that will address these challenges that we had in Ashanti region. So we decided to form 4 tiers of approaches. One was to establish a national advisory team to the Minister of Health, and then to also have a national technical steering committee. Then we also had a regional steering committee and the district implementation committees. These are committees that we have set up to decentralize the rollout process of capitation in these regions. We have also decided this time to come up with a communication strategy that looks at individual districts, individual ethnic and individual community compositions in these regions that we are talking about. Also, we also try to look at the type of facilities and the logistics preparedness in these facilities. So we have gone around and we have been able to do what we call facility mapping, where we have established that out of the 3 regions we have 899 facilities. We try to see their human resource needs and status. We try to see their logistic needs and status and see whether if we roll out capitation, it will not affect patient care. So currently that is what we have done. We have communicated with the ministry. We have certain policy challenges that we are trying to look at now, and we are discussing with stakeholders as well as the Minister of Health. One of them has to do with the definition of primary care. It's like we are still using the 1978 Alma Mater definition of primary care, which is not Ghana specific. We need Ghana specific definition of primary care. Also, we have a tier system of care that's from the service point of view and the public point of view. Service starts at the CHIPS compound before health center and district hospitals and above. Now, the challenge we have had is that the CHIPS compounds are limited in terms of what they can do. So if you start capitation at the CHIPS compound, are they going to pay them a different rate from the health centers? This is what we want the Ministry of Health to help us to iron out. We have also looked at additions such as family planning or long-term family planning, immunization, so that it can take care of the public health activities that go on, which hitherto was not in the previous package. We are also looking at the possibility of group practice and whether various facilities, whether they are for public or private, can come together and perform the function of patient care. And then how are they going to share the monies that come to them? Now, we also have asked the ministry to also mobilize resources so that we can pay off all the outstanding debt we have in those 3 regions before we start. And then can we also have an assurance that for 1 year we can have monies that will be advanced, and since capitation is a prepaid method of payment. Are we sure we can get the money for 1 year even before we start? These are some of the issues that we are still deliberating on. But I want to tell you that as we sit today, in terms of the communication, we have had sponsorship from USAID who are taking care of the communication strategy. We have been able to come up with a strategy document that we have sensitized the district PROs, or the public relation officers, the district managers, the district assemblies, then the chiefs and opinion leaders in all the districts that we are going to roll out capitation. We have currently come out with a rollout plan that will be community debates, and as I'm talking to you now, the team has been prepared, logistics are ready for us to move into the communities to do community debates and sensitize them. The challenge that people are currently raising has to do with enrollment. What method are we going to use in enrollment? We thought that by using paper enrollment, we'll be giving excess burden, and it is also not environmentally friendly. So we are looking at the possibility of using tablets to enroll. The discussion has gone on. We are currently hoping that before the end of April, we'll be able to secure up to 1,000 tablets, and then we could do the enrollment with the tablets. We may also have a problem with connectivity. Fortunately, the use of the tablet will not be dependent on internet connectivity, so we'll be able to do it safely. I want to say that as we stand today, the districts that we are going to implement capitation are fully prepared for us to come. We're just waiting for the policy directive from the Minister of Health, and we'll roll out. Yeah, currently, I actually strongly would like some few answers from JLN. What has made capitation successful in other countries? What were the challenges that those countries faced? Are they different from what Ghana is facing now? And how did they overcome them? If we get these answers, it will go a long way to help us in making sure that we ensure effective and efficient running of NHIS. That will also ensure sustainability of the scheme, which is currently being challenged by a funding gap. Thank you very much.